Thank you, Dr. Walker, for inviting me to participate in this very important NCVH digital educational series. My topic is critical limb-threatening ischemia, and I will try to answer 3 questions. Are we saving limbs but losing lives? Is best medical treatment good enough? And can we do better with selective coronary revascularization? Here's my disclosure. Critical limb-threatening ischemia affects more than 10 million patients in the United States with a threat to limb loss and loss of life. Patients who undergo lower extremity revascularization have a high risk of cardiac complications, death or myocardial infarction, and have reduced long-term survival. This is due to coexistent coronary artery disease, which is often unrecognized since patients are sedentary and often have no chest pain or cardiac symptoms. Clinical practice guidelines recommend lower extremity revascularization to prevent amputation, but it does not recommend routine preoperative cardiac stress testing because there's no benefit from preoperative coronary revascularization. Thus, the recommendation is for best medical therapy for atherosclerosis. Accordingly, most patients undergo revascularization without knowledge of the functional significance of their coronary artery disease. So how are we doing on saving limbs and saving lives? Look at this central illustration from the nationwide trend of hospital admissions for patients with critical limb ischemia from 2003 to 2011. This is a national inpatient sample of more than 600,000 admissions. The number of patients admitted for CLI is about the same, 150 per 100,000 population. And it's encouraging to see a declining rate of amputations from 16.7% to 10.8%. Mortality also decreased from 5.4% to 3.4%. Endovascular treatments had a lower in-hospital mortality than open surgery, but this was associated with shorter hospital stay, 8 days, as opposed to 11 days for open surgery. Now, it's interesting as you look at this graph that in 2008, the rates of increasing endovascular treatment and decreasing surgical treatment kind of come to a meeting point and stay the same. Well, what happened in 2008? Medicare reimbursed outpatient treatment for critical limb ischemia. And so after 2008, the rates of endovascular treatment as an outpatient soared, and now more than 80% of patients are treated endovascularly. But we don't know what the mortality rates are since these are outpatient treatments. So it's more important to look at 30-day mortality rates. And 30-day mortality rates for critical limb-threatening ischemia is astoundingly high, about 5%. And this is true for both endovascular and open surgical treatment. More importantly, those who have postoperative myocardial infarction or postoperative myocardial injury, troponin leaks, which can occur in up to 20% of patients, have markedly reduced survival. So if we look at this graph from the Vascular Society of New England showing the 5-year survival rates, we see that for all patients undergoing peripheral arterial disease, 73% are alive at 5 years. It's much lower for those who have troponin leaks, 54%, and those who actually have myocardial infarctions, only 33% are still alive 5 years later. These are astoundingly high mortality rates, higher than anything from almost all cancers and certainly higher than for coronary artery disease. So what should we do with peripheral arterial disease patients because of this high mortality rate? Well, guidelines say best medical therapy, risk factor control, smoking cessation, antihypertensive, statins, antiplatelets, and glycemic control for patients with diabetes. And when patients with peripheral arterial disease continue to have high mortality rates, that's attributed usually to a low compliance with best medical therapy. But despite best efforts at medical therapy for peripheral arterial disease patients, we have seen no reduction in mortality over the past decade, despite best medical treatment. So a very recent publication that came out in JAMA Surgery showed a high mortality rate with postoperative myocardial infarction in major vascular surgery, despite use of evidence-based medical therapy. This was a statewide registry, state of Michigan, 26,000 patients over a 5-year period, 2012 to 2017. Postoperative myocardial infarction in patients undergoing peripheral bypass surgery was 2.6%. And what was really astounding about this study was that the 1-year mortality in these patients was 45%, even though almost all patients followed best guideline medical therapy. And this high mortality stands in very stark contrast to the survival rate of patients who experience myocardial infarctions, much lower, 3.8%. So why do patients who have myocardial infarctions have a relatively low 1-year mortality, whereas patients who have myocardial infarctions after vascular surgery have an astoundingly high mortality? Well, perhaps because they're treated differently. Patients who have myocardial infarctions have angiography and have coronary revascularization. So what about coronary revascularization for PAD patients? Well, guidelines recommend against that. And they recommend against coronary revascularization because of prospective randomized trial evidence. Now, that trial is called the Coronary Artery Revascularization Prophylaxis Study, CARP. And that randomized patients to preoperative coronary angiography and revascularization, or preoperative coronary angiography and no coronary revascularization. The 30-day mortality rate in the two groups was the same, 3.1% and 3.4%. A lot of patients had troponin leaks, and the 30-day myocardial infarction rate was 12% and 14%, not different between the two groups. And there was a very high mortality at 2.7 years in both groups, 22% and 3%. So there was no reduction in mortality with preoperative coronary revascularization, but there was still very high mortality in both groups. So the conclusion of the study was that coronary revascularization before elective vascular surgery does not alter the long-term outcome. Well, this study, if you think about it, is outdated. It was published in 2004, 16 years ago. And that was 5 years before the FAME publications came out. Now, the FAME publications we'll talk about in a moment. They're the ones that established fractional flow reserve guided coronary revascularization. The other thing that happened in the CARP study was because it required pre-vascular surgery coronary revascularization, it delayed needed vascular surgery by about 2 months. Now, think about that. Patients with critical limb ischemia, with gangrene, ulcerations, critical threat of limb loss, had their vascular revascularization delayed by 2 months. And so the question is, why does coronary revascularization have to be done before vascular surgery in order to achieve long-term survival? Well, fractional flow reserve is measured in the cath lab, and it defines the functional significance of coronary lesions. So if a coronary stenosis has an FFR of less than 0.8, it is hemodynamically significant. It's obstructing blood flow and will benefit from coronary revascularization. Visual assessment of that coronary stenosis, as was done in the CARP trial, does not define that, and you can't tell whether that stenosis is obstructing blood flow or not. There are three prospective randomized trials, DEFER, FAME-1, and FAME-2, that showed a significant benefit of FFR-guided revascularization compared to visual angiography revascularization. And this is now the standard of care of treatment of patients with coronary artery disease. Prospective trials show reduced death and myocardial infarction with FFR-guided revascularization. Also within those trials, those patients who were asymptomatic coronary-wise, that is, they had silent coronary ischemia, had a twofold higher death rate at 5 years compared to those who had symptomatic ischemia. That again also makes you think, right? Because symptomatic patients will get treated and get coronary revascularization. Asymptomatic patients frequently don't get the treatment that they need. In a real world experience now with two very large studies that were recently published, 18,000 patients in the VA study showed a lower 1-year mortality, 2.8% versus 5.9%, using FFR guidance as opposed to visual guidance for coronary revascularization. And in a Swedish registry of 24,000 patients, in 5 years, there was a significant reduction in mortality with FFR-guided revascularization. Well, now it's possible to get that same measure, fractional flow reserve, non-invasively based on coronary CT angiography. This is a computational technique which provides a three-dimensional map of FFR values throughout the coronary tree. It is color-coded, and as you can see on the visual, if it's red, then that means it's hemodynamically significant. Below 0.8, and if it's blue or blue-green, it's above 0.8. Computed FFR is validated against invasive FFR and correlates well with the invasive measurements. It reliably differentiates ischemia-producing coronary stenosis from non-functional lesions. It is FDA cleared, Medicare and private insurance reimbursed for use in symptomatic patients with coronary artery disease. It's been used to evaluate more than 50,000 patients with suspected coronary disease in the United States, Europe, Canada, and Japan. So with CT-FFR, you combine anatomy and physiology. So the CT scan alone here in these two patients shows a 70% stenosis in the left anterior descending artery. You can see calcium. You can see patient A has what looks like an obvious stenosis, and the calcified lesions in the patient B are also seen. So which one of these two is hemodynamically significant and could benefit from coronary revascularization? Well, if you do computational analysis, you see that the patient A does not have a functionally significant lesion. The FFR value is 0.86, and this patient could well be treated medically. On the other hand, patient B has a significant stenosis with FFR value of 0.70, and this patient could benefit from coronary revascularization. Well, a computational model is validated by angiography and measurement of FFR, and you can see that the angiographic findings correlate well with the computed findings, and these now are well-validated techniques. What about applying these techniques to patients with peripheral arterial disease? So in Riga, Latvia, their clinical site participated in all three validation studies for invasive FFR versus computed FFR. There were more than 1,000 patients in Discover Flow, De facto, and NXT. So when it came time to try to answer questions for peripheral arterial disease patients, we turned to the vascular surgeons in Riga to do the study. So they did preoperative assessment of patients with peripheral arterial disease in a prospective trial to try to answer the questions of what is the prevalence of unsuspected lesion-specific ischemia. How should this ischemia be managed? And is there a role for selective coronary revascularization to reduce cardiac complications and improve outcome? The first report from this study appeared in 2018 in Vascular Disease Management. It showed a high prevalence of asymptomatic ischemia-producing coronary stenosis in patients with critical ischemia. These were 54 patients with no cardiac symptoms admitted and cleared for surgical revascularization. FFRCT analysis showed that 69% of these patients had coronary ischemia. Now, they had no cardiac symptoms, so they had silent coronary ischemia. Now, what do we do with this information? Well, these patients had critical limb-threatening ischemia, so they needed peripheral revascularization, which they got in 91% of the patients. This was done safely. There were no deaths or myocardial infarctions in the 30-day period. Postoperatively, however, the patients then had this information available, and the physicians selected patients for coronary revascularization. An example is shown on the right. This is a 59-year-old man with ischemic rest pain. His preoperative studies showed a severe stenosis in the right coronary artery with FFR of 0.71. He successfully had his revascularization surgery, and then 1 month post-op, the right coronary artery was revascularized with a stent, as you can see below. Severe stenosis on the angiogram and the postoperative image with relief of that stenosis with a coronary stent. So to answer the broader question, does this really benefit patients by reducing death and myocardial infarction and improving survival? A prospective study was done in Riga, Latvia with the principal investigator, Dr. Dainis Kadievins, and he presented this material at the European Society for Vascular Surgery in Hamburg in 2019. And this manuscript is now in press at the European Journal of Vascular and Endovascular Surgery. This was a comparative study comparing the open label IR-approved prospective study of preoperative cardiac evaluation with CTA and FFRCT compared to a historic control group of matched patients with no cardiac history or coronary symptoms who underwent elective lower extremity revascularization during the immediately preceding prior year before the prospective study was performed. These patients had standard preoperative cardiac evaluation, history, physical exam, electrocardiogram. They had no cardiac history or symptoms, so they did not have any cardiac imaging studies. The endpoints for this comparative study were cardiovascular death, myocardial infarction, all-cause death, and major adverse cardiac events, which were defined as cardiovascular death, myocardial infarction, or unplanned coronary revascularization. The two study groups were similar in age and gender distribution. The comorbidities were no different, as the medications were the same. And interestingly, the operative indications for both groups was critical limb-threatening ischemia in the vast majority of patients. 86% of patients in the CT-FFR group and 82% of patients in the historic control group. 40% of the patients had inflow procedures and 60% of the patients had outflow procedures. Now, patients in the CT-FFR group had coronary angiography first. And as you might expect in patients with severe peripheral vascular disease, they had a lot of calcification. Now, calcification can interfere with coronary angiography, and guidelines recommend that you not do CT angiography in patients who have calcium scores greater than 400. In this experience with peripheral vascular disease, the calcium scores was greater than 1,000 in most patients. The mean Agassiz score was 1,156 with a range from 0 to 4,810. Now, this did not interfere with performing FFRCT evaluation computationally, and I'll show you those results in a moment. The other thing that was remarkable about the CT angiography was that left main stenosis was present in 7% of patients. This is consistent with the prevalence of CT of left main stenosis in the Ischemia trial, and also patients in the CARP trial had a high prevalence of left main stenosis, but those patients were routinely removed from the prospective trial so that the highest risk patients are frequently absent from a lot of the trials. 50% coronary stenosis or greater was present in 70% of patients. So what did the FFRCT analysis show? Well, it showed that 68% of the patients had silent coronary ischemia. 32%, as you see on the left, had no evidence of coronary stenosis with good perfusion of the myocardium. 30% of the patients had single vessel disease, as seen in the middle, and 38% of the patients had severe multi-vessel disease. In this case, the 59-year-old patient had right coronary artery occlusion and severe stenosis of the LAD and left circumflex artery. What's more is that severe ischemia, defined as FFRCT less than 0.75, was present in 53% of the patients. Mean FFRCT value was 0.7 in patients with ischemia. So the lower the FFR, the higher the risk of the patients. So these were severely diseased patients with very severe coronary artery disease, yet none of them had coronary symptoms. So how were these patients managed? In the prospective study, the planned vascular surgery was performed in 96% of the patients. In 5 patients, it was postponed, 1 for coronary revascularization and 4 for medical treatment. Importantly, there were no postoperative deaths and only 1 postoperative myocardial infarction. In the control group, vascular surgery was performed in all 135 patients. All had standard care, none had coronary symptoms, and yet there were 5 postoperative deaths and 7 postoperative myocardial infarctions. After surgery, both groups received optimal medical care. Patients with silent ischemia received postoperative coronary revascularization. That occurred in 72% of patients with silent ischemia. The patients underwent elective coronary angiography 1 to 3 months after vascular surgery, and particularly those with left main disease, severe ischemia, and multi-vessel disease. PCI was performed in 47 patients and coronary bypass in 7 patients. On the right, you see an example of a patient with left main stenosis and severe multi-vessel ischemia who underwent coronary artery bypass 6 weeks after successful lower extremity revascularization. Here we see a typical scheme. Patients present with peripheral vascular disease, severe critical ischemia. You can see this is a CT scan showing occlusion of a femoral artery and proximal popliteal artery. Preoperative coronary CT scans shows a lot of calcification. It suggests a 70% right coronary stenosis, but no significant left anterior descending stenosis. And this is now correlated with the FFRCT analysis, which showed that there is no significant obstruction in the right coronary artery. It's all blue. Yet there is a severe focal stenosis in the left anterior descending, where we see the red arrow, with severe distal ischemia past that stenosis. Patient had successful femoral popliteal bypass, and then coronary angiography was performed 1 month later. You can see that the right coronary stenosis confirms absence of stenosis. The LAD coronary angiogram reveals a 90% LAD stenosis with the red arrow, and coronary revascularization is performed with a stent with complete relief of that stenosis. So what are the results? Well, there's no significant difference in 30-day outcome between the two groups. There was a trend toward reduced cardiac events in the CTA-FFRC group compared to control, but these were not statistically significant. You may wonder why might there be a difference early on? Well, this was an open label study, and physicians knew the results of the FFRCT analysis, so that perhaps patients who had severe coronary disease had more focused treatment on their coronary disease with better attention to their cardiac disease. We know that severe patients with severe coronary disease can be successfully operated on most of the time. However, at 1 year, we see a very significant difference in outcome, perhaps related to the coronary revascularization that these patients had. Cardiovascular death was reduced 0.8% compared to the control group of 5.9%. Myocardial infarction was reduced 2.2% compared to 8.1%, and all-cause death was reduced compared to control. Kaplan-Meier analysis at 1 year reveals reduced cardiovascular death, reduced myocardial infarction, and 1 year survival of 99% in the CT-FFR group and 94% in the historic control. Thus, in summary, patients with no cardiac symptoms undergoing elective lower extremity surgical revascularization have a high prevalence, 68%, of unsuspected silent coronary ischemia, which may increase the risk of death and myocardial infarction. Preoperative cardiac evaluation using coronary CT derived FFR can identify high-risk patients with silent ischemia and facilitate multidisciplinary patient care with selective postoperative coronary revascularization. This resulted in fewer cardiovascular deaths and myocardial infarctions and improved 1 year survival compared to historic controls with standard preoperative cardiac evaluation and patient care. So to answer the three questions that we posed, are we saving limbs but losing lives? I think the answer is yes. Is best medical treatment good enough? Definitely not. Can we do better with selective coronary revascularization? I think so, but we don't yet have the proof. This is a single center study. We need prospective randomized trials and more evidence before we know for sure what the best strategy is for patients with peripheral vascular disease. Thank you very much for your attention.